Okay, so here are the topics that you covered. These are almost all the ones that you covered this morning. There may be a couple that I've eliminated just because they are redundant or there's just not much to them. So that's what we're going to go through today. Let me show you the learning objectives because they're a little bit different. I tried to look through the topics and look for where are there just redundancies and things that we ask you to know. So these you will find at the very beginning of your handout. And these apply to every class. I mean, not every class, but every disease or condition. So it's identify treatment goals and monitoring parameters. The other is antibiotic of choice. So I understand from your boards what they will ask you is drugs of choice, and if there is a reason why you can't use that drug of choice, then what's second line? Or if a person is allergic, what do you use? If they're immunocompromised, what do you use? If they're pregnant, what do you use? If it's a child, what do you use? Okay? So I try to hit those where it is available. So second line's there. Identify the place in therapy. So it's important to know where a drug fits. If you choose the fourth line drug, then someone will probably ask you why you're doing that. Sometimes those drugs are more expensive, they don't have as much evidence behind them. So knowing where a drug, usually in the category, if this doesn't work, what's my next go-to? Or if the person has this disease, what do I go to? If this contraindication exists, what's my drug? Okay. Then when provided, mechanism of action, we're going to cover some of those. Here's one of the problems we have discovered is that you have some drugs that are just a part of many, many disease states. And you have some drugs that are very specific for a disease or an organ or just several diseases. So it makes it difficult when you start with something like antibiotic because you don't have any background for it. And it is such a wide class to say antibiotic that what we've decided, the faculty have discussed it, is we're just going to give you here's the name of the drug. And then we're going to go back and we will do more of an overview on antibiotics because you will see them over and over and over again. But for some, I'll give you more specific actions. To me, you should not use a drug if you don't have some idea what it's going to do. It will make more sense what you're trying to accomplish if you know that. And side effects are more easy to understand and to pick up on if you understand what the drug is doing generally in the body. We'll also talk about the most common causative organisms because that's what drives an antibiotic choice. One is anatomically, where is it? What's the most likely bug that's causing it? And what's the resistant patterns in the place where you practice? So I can teach you here, but if you go out to Godibo or if you go down to Texas, their susceptibility patterns are going to be different. They're not going to be hugely different, but they're going to be enough that they're going to tell you we don't use that antibiotic because our resistant patterns in this hospital, in this community are different. So that will drive some of the drugs that you choose. Contact lens wearers are a different category, so we'll separate them out for at least a couple of the different eye problems, and maybe you did that today. I talked to Professor Fetters before I came down because she and I did not get to go and match up exactly what we were saying in terms of therapy. She said she deferred to what we're talking here to be what you're going to, because I'll write the pharmacology questions, pharmacotherapy up for the test. But I would, if there are discrepancies, please bring those up. You can go to several different, and I found this when I went to a few for topics I didn't know, like preseptal cellulitis, I never deal with it. So, but I found different recommendations. So I usually go to Up to Date will be usually my last go-to because they are so good about telling you exactly when it was updated, and it's so well annotated that I feel like it, and it's usually expert opinion. So she and I have kind of agreed on that, but I do want you to bring up inconsistencies that you find. Because that more is a trouble for you. It isn't a trouble for us because you get used to living in that gray zone. That's medicine, it's just gray. There's very few black and whites, very few. So for your standpoint, that's hard because you want black and whites. It makes it easier. Cookbooks, easier. Okay. So we understand that, so bring those up as you see them. Okay, questions about these general? Now, in a section, I may give you additional ones because there's something in that disease or that therapy that I want you to know in addition to these. Okay. All right. Let's go with dry eye syndrome then. Ever had dry eyes? Anybody ever self-treated with dry eyes? Okay, pretty common. In all age groups, lots of drugs cause it as people get older. Oklahoma is terrible for it because the wind blows constantly and we're low humidity and we have a lot of dust. So you see a lot of it in this area. So treatment goals and monitoring parameters you're going to find for almost everything what we talk about. So a treatment goal, let's kind of talk about why they are so important because they drive what you do. Okay. So let's say we're going to go to St. Louis. Okay. That tells us our goal, right? So we have a goal. We're going to set out, we know where we want to end up. Okay. How many ways can I get to St. Louis?
A lot.
A lot. And how many different vehicles or modes of transportation can I take? What could I do?
Plane.
I could do a plane.
Drive.
I could drive.
Train.
Train. Bus. Could I walk?
Yeah.
I could. Could I run?
Yeah.
Bicycle? I could cycle. Okay. Horse? Okay. So that's like your drugs. That's like your drugs. We named 8 different ways to get to our goal. Okay. How do those differ? Tell me how all those modes differ. Speed, time, cost,
Efficiency.
efficiency, route, wear and tear on the user, right? Safety. Okay. Same thing with a drug. Every drug has all those same things in it, and that will determine when we use it, our place in therapy, how insurance looks at it, how patients go look at it, same thing. So that's a goal. That's why a goal is so important. You can never use a drug and not know where you're headed. You just can't do it. You will mess up. Can't do it. And nowadays, almost everything you will treat already has a goal already set out. Okay. Now, monitoring parameters. So, in getting to St. Louis and in our different routes, how will we know that we are headed towards our goal? How would I know? Pardon?
Road signs.
Road signs? Oh, come on.
Yeah.
If you all don't talk, you're going to fall asleep. A map. Okay, so I could get a folded out map.
GPS.
What you all more likely use a GPS on your phone. Okay, what else?
Ask somebody who knows.
You could ask for directions. Okay, where else? Landmarks. Okay. Can I look at the odometer? It'll tell me some in between. Same thing with the monitoring parameter. It tells you whether you're getting to your goal or not. So they're really important. So that's for efficacy. Now, how am I going to ensure that I can safely get to St. Louis? Okay, a seatbelt. That'll get me there. Okay, what else? Speed, okay. Okay, surely your dads, there's too many women in here. Sure, what'd your dad tell you before you set out on a trip?
Be careful.
Okay, be careful, what else?
Make
Gas,
sure you
fill up your tank,
Tire pressure,
check your tires. Okay, that's right, if you break down, you gotta protect yourself. Okay, so those are like your safety things. Those are the things that you are looking at to make sure that the common side effects that drug causes, or the most dangerous, even if they're very rare, that you have some surveillance in place in order to pick those up. Okay? So all those things are akin to using a drug, same thing. So for dry eyes, what we're trying to do is make what drives people is making their symptoms go away. Also to prevent potential damage. You get enough of that tear film that's broken up or dries out, then the eye is more vulnerable to damage. We're going to monitor it by its simply response. Sometimes it's just, how does it feel? Those are simple things. alleviation of symptoms, and their ability to administer the drug is also part of that. Okay, so y'all talk about the tear film and the eyeball. Okay, so what the drugs that are out there now, the products that are out there for dry eyes are so good that they address almost all of these. The more complicated ones, the more ingredients they have, they will address more of either the lipid layer, the aqueous layer, the mucin layer, all of that, whether the tear film is intact or not. And these products can be fairly expensive. They can be $10 to $15 over the counter. Okay, the good ones will be. I will show you the ingredients. I can tell you about a few of the products, but I'll tell you the thing with over-the-counter products is they are notorious for change. So today, what you know about when you walk out the door with your degree, they'll all be different, and they'll probably be better. So I can tell you a few, but I'm not going to tell you a product to hang your hat on. But I'll tell you ingredients so that you can walk into a pharmacy, pick it up, and look at it and go, oh, this is this. Okay, so they're over the counter. So anybody can buy them. Anybody can treat themselves with them. They come as solutions or ointments. The solutions range from fairly liquidy drops to very almost a suspension-like drops. So their viscosity is different. And then there's also something new that has started showing up are gels. So the gels are good because they're somewhere in between. They've got the staying power of a ointment, but they don't make your eyes blurry and gunky. So the ingredients in lubricant are in the ophthalmic lubricants are the lubricant itself, preservatives, which can get us into trouble, so we'll talk about those, lipids, polymers, and the osmoprotectants. There's also other things that are added to keep the in isotonic so that it doesn't burn the eye when it's put in. That's for comfort. Okay, so lubricants. So what lubricants do is they stabilize the tear film. And some of them have mucomimetic properties. They will differ in viscosity. And the drier the eyes, the more symptomatic somebody is, may want something more viscous because it'll stay in there longer. The problem with viscosity is it blurs your eyes. So usually people who have just mild, like I have mild dry eyes, I just use a very a less viscous drop, and it does me fine. The ingredients, so if you pick up a bottle, here's what you'll see. Usually these are the first ingredients, not always, but usually the first. So any of the cellulose, methyl cellulose, carboxy, methyl cellulose, hypromellose, all those are lubricants. They're fairly viscous. The PVA and the povidone, they're good. They usually will be the less viscous, but they're very good. Glycerin, dextran, PG400, all of those are lubricants. Next are preservatives. Preservatives are there to keep the bacterial growth down. So if you have a multi-use product, you want a preservative in them. Most of the time preservatives aren't a problem if you've got somebody who has mild disease and they're only going to use it once or twice a day. It's the folks that use it often, because you can use it as much as you want. People usually don't do that, but you can use it hourly. Okay? So some of the preservatives, and the one that is most problematic is that benzalkonium chloride. The reason it's there is that it is so good, and it keeps that product usually microbe-free for the length of the time that the person uses it. The problem is that it is toxic to the cornea. So over time, it will cause trouble. So what I put in your handout is if you are if someone's using a product 4 or more times a day, they should avoid products with benzalkonium chloride, or BKA is how they also shorten it. Now, I put two things up there. They come up with these new preservatives called vanishing preservatives. They're really cool. They keep, as long as they're in the bottle that you buy and they're intact, they keep your solution free of bacteria. As soon as you put it into the eye, when it hits the eye, it will dissociate and form water or hydrogen peroxide and then water and oxygen. It's cool, just evaporates. Now that's cool. So those are like those, you're brand new, I don't even know my brand. Purite, perborate, I think is one of them. Sorry. Yeah, sodium perborate and purite. So if you look at that, you can tell by looking at the label. Now the preservative-free are truly preservative-free, and if you look up there with that sustain, you see that they are in individual tubes. These are probably the most expensive, but they are individual, they're unit dosed, so they may come in 30 of those individual vials. No preservatives, you open one, use it, toss it. So you can never keep it. So those are going to be your most expensive, probably for the folks who are going to use them a lot, who are very sensitive to other, to maybe the preservatives themselves. Okay, so those are cool. They're expensive. Other ingredients, the lipids, just like it says. The mineral oil is probably the most common. That this drinkiol is actually a very highly refined mineral oil, and those go to that lipid layer. So those will coat that the eye and keep it moisturized for a very long time. Polymers are a matrix that is set up that's also meant to keep that aqueous and that lipid layer in contact for longer. So you'll see those listed as hydroxypropyl GAR or that copolymer or polymer matrix. Yes?
Saying whether or not it's preservative-free, is that monitored by the FDA? Like, or can anyone just say that and?
No, those you couldn't make a claim without it being there, no. But I'm glad you asked, but no, they can't do that. Osmoprotectants are really a very new thing. They keep the osmolality of the, or the osmolarity, sorry, of the product down. So that's L-carnitine and erythritol are those products. So again, these are going to be the products you would use and people are using them more often. They're going to be the more expensive products. People are really having a hard time, more severe disease would benefit from those. Tonicity, those are usually going to be sodium something, and they're added to make it isotonic so that it'll decrease the burning and stinging when they instill them. So again, they can be used as often as needed. Usually folks that have got mild disease, 1 to 2 times a day is fine. They can titrate it to whatever they need, use it as needed. More severe, moderate to severe, usually need 3 or 4 times a day. They may also benefit from putting an ointment in their eye at night, or the gel in their eye at night. Again, they will wake up with blurry vision. Usually it takes about 20 minutes to clear. There's also, when I talk about the ointments, let me go back, just let's see if I put anything there. If you look in your handout or on the bottom of page 5, they're called non-medicated ophthalmic lubricants or ointments or gels. Those are the ingredients are fairly standard: white petrolatum, mineral oil, or lanolin. Okay. So those are just lubricants. There's no medicine, there's nothing in there that's going to do anything but that. So that would be the thing to use like at bedtime, at night. Most of the time people don't like to use them during the day because it really does take a while for it to clear. Ointments are a little bit harder to put in as well, so you usually find people who like them at night. Very few adverse effects. Most of the time you're looking at the preservatives are the more irritating thing to the eye and the blurriness, and that's about it. And then cost. I think people will be surprised. I mean, next time you're in a drugstore, go by and just pick them up. Last time I looked, they're in about the $10 to $15 range per bottle. Usually a bottle will last folks about a month. So it's not bad, but it's kind of a shock. If you look at the old, I would not recommend the store brand generics, I just wouldn't. I'd go with these other products if you've got, somebody's got moderate to severe. Yeah.
I used to work with an ophthalmologist who would
Yeah.
just like pass out ridiculous amounts of samples. Like how common is that?
Oh.
Just to save her patients cost at the drugstore.
I would say that they're the only group that's gonna get it, are gonna be the ophthalmologists. You probably will never see them. I'd be surprised. But the ophthalmologists, they want their favor, they want them also promoting it, and if you got an ophthalmologist standing behind your product, it has higher standing. If you've got a leader in an area, so. I'd be curious, what did you all?
She almost always used all the Sustain stuff. 'Cause
Sustain.
Because she hated the preservatives.
Yeah.
Sustain is good, it really is. It's one of the more expensive ones though. Okay. Geriatrics, they are going in kids, so just a couple of things. One is the hygiene. For children, what they recommend, and I am no expert, is that you have them lay down, close their eyes, and you put it right in the corner. And if they blink a little bit, it will draw it into the eyeball. And that shows you with the ointment down at the bottom. To me, it's not real clear. It's showing that you do not want to touch that tip into the eye. Here's some products that are available. There's quite a few, and anybody can use them, but I find geriatrics, I tend to find that they have a little bit harder trouble strength-wise or just coordination-wise, especially if they have a trimmer. So these are different products. The one that kind of looks like something out of Star Wars, that helps them. If you can get it to the eye, then they can squeeze that and it will do the drop for them. The others are more stabilizing, and they put it right over the eyeball. You squeeze it, it goes right in. Okay. There's a ton of these out there, so it would come down to whatever they tended to work for them. The one thing you can do, and when we talk about the glaucoma medicines, it'll become important, is that once people put a drop in, we ask them to just put pressure for about 5 minutes over on the side. It allows the medicine to stay on the eyeball longer before it goes down the tear ducts and into the nose and the rest of the body. That's the one problem with anything you put into the eye. It gets in systemic because the tears will get rid of it very quickly, and then it's down the nose and then well absorbed. If you have to do multiple drops, we recommend about 5 minutes in between. Now, I've read it anywhere from 3 to 5 minutes. Here's my trick. I always tell people 5 minutes, they'll never wait that long. So if I can get them close to that, then that will help if they have to do multiple. You probably have seen the commercials for Restasis. So this is cyclosporin. It's an immunomodulator, but very effective anti-inflammatory agent. So people who have a lot of inflammation with their eyes, this is a more down the line. You've tried everything else and you still have quite dry eyes, this would be a drug that could be considered. It's a prescription item, so and it's the only one in this class to treat. Okay, questions about dry eyes?
Where exactly are you putting pressure on?
With that tear duct, so usually you just press it up against the nose, just so it doesn't drain.
So the nose.
Well, I am putting it right beside where that tear duct is
Okay.
and pressing that against my nose, just to keep it from draining out so quickly.
Okay.
Okay. All right. There's the Restasis. It's going to come as I don't think it comes as a bottle. Do you know, Braden, did you ever see it? You're saying no, Melissa?
Yeah, I don't know.
I think it just comes as individual, and that probably makes sense because the overdosing of it, or you want to control the amount.
They gave it after our LASIK eye surgery, so it reduced
Oh, really? Like one
inflammation.
drop?
Mm.
Yeah, that's interesting. Okay. Those would be off-label. This is off-label for dry eyes as well. No, I'm sorry, this is not. There's another area where I'm going to mention it that it's off-label. This is what it was indicated for. Okay. Let's go on to styes. Styes are pretty easy from our standpoint because there's really not a whole lot to do unless they don't respond to just very minimal, like compresses. Then you need to get them on to somebody who is an ophthalmologist. So it's warm, moist compresses. So I went out just to Google compresses so I could have a picture of them, and I came up with all this interesting stuff. So have you ever seen the Stye guy? He has video clips on YouTube. He's very charming, but he shows you how to make a compress out of rice and a sock. But he was getting married, and his fiance had given him groom socks. So he made the compress out of groom socks, and I thought, you are in such trouble. I mean, it's those socks that they wear when they get married. So I didn't know you could do this. So about a half a cup of rice in a sock, put it in the microwave and warm it up. It makes a fairly good, decent compress. And then I guess Ellen DeGeneres kept coming up in all my searches, so I went in there to see what happened with her, and she had a Stye. And of course, she came out that day and she said, I can't ignore it, so I got to tell you what this is. And then somebody made her an eye with an eye patch. I thought it was cute. That's what it was. Anyway. So it's Staph aureus is going to be the bug if you have to treat. So then you would use like an erythromycin or bacitracin antibiotic if it was needed. But as far as I know, they really do recommend moving that on to a specialist if they're not responsive because of just the multiple or the nature, or it then turning into is chalazion the way you say it? The next. What'd she say?
It's like chalazion or something.
Chalazion. So it was a hard sound instead of like a chuck instead of a.
Yeah, she did.
Chalazion?
Yeah.
Okay.
Chalazion.
She did. Okay, all right. Okay, let's talk about blepharitis then. So here our goals are going to be is getting rid of the infection and good lid hygiene since it's a recurring problem, and trying to keep this. So the staph aren't so much the problem, it's the lipases that they produce and irritate the eye. So here again, we've got warm compresses. You can use baby shampoo or also Selsun Blue or selenium containing shampoo. It would be very effective. It would be a lot more irritating though to the eyes than the baby shampoo. And then good hygiene, and so a lot of patient education about how to take care of those eyes to keep it from coming back. So antibiotic covers is going to be for Staph aureus, so that'll drive our antibiotics. So erythromycin, bacitracin, really good coverage, and usually ointment is what is involved. Antibiotic corticosteroids are sometimes used for the inflammation, but if it doesn't respond to the antibiotic by itself. Did you all talk about corticosteroids in the eye today?
She mentioned that we can.
Okay, and that's probably good because they are just so lethal to the eye if used inappropriately for too long. So increase in intraocular pressure and cataract formation is the real problem in the eye with prolonged steroid use. And then oral antibiotics can be used for refractory or severe cases. So fairly straightforward.
Do we remove the crests in this? Or do we send them to an
I think you can do it. I mean, I don't, that is not the hard part. Yeah, and I think you need to teach the patients how to do it because they will need to do it on a regular basis. Okay. Oral antibiotics, I put this in as a note because if you had to go to oral agents, this is just a reminder about tetracyclines. Not using them in kids 12 and under, pregnant women, because of anything that's calcifying, tetracycline will lay itself down in it. And with children, you can certainly get those gray or bluish gray stained teeth that are permanent. Zithromycin is more expensive. It's a very good staph coverage, could also be used. And this is where Restasis, if you've got a lot of inflammation, this is an off-label use for this, for blepharitis. The other, in below the teeth, I wanted to show you photosensitization. Because tetracyclines, this would be like minocycline, doxycycline, tetracycline, those are all the same derivatives. They sensitize the skin to the effects of the sun. So what happens is any sun-exposed area gets and it's like a sunburn, but it's a mega sunburn, and it can be extremely damaging. So anybody that's on those tetracyclines really has to be instructed to stay out of the sun for a prolonged period of time, especially at the, like in like a football afternoon game outside. You would not want to go out without protection. Now, if they wear sunscreen, it can prevent that, but you really want to avoid prolonged sun. So that gives you an idea of what it can look like. You can see that it's like a sunburn, but you still get an even more breakdown of the skin. Okay. That's it with blepharitis. It's mostly going. It's mostly going to be topical. Sorry. Okay. So let's talk about the conjunctivitis. We'll talk about bacterial, allergic, and viral. So again, most of the time with the eye, we are talking about, unless we've got a major trauma to the eye, we're always talking about skin organisms, so staph and strep. And then Haemophilus in very warm areas. I don't know that that is a problem in our area, but staph and strep would be the ones that you'd be wanting to cover. So again, the goal here, for most of these, is going to be eradicate the infection and relieve the symptoms. For efficacy, it's going to be when do you expect response? Most of the time, when you are treating a straight out infection, within 1 to 2 days, you should see major improvement. If you've ever been treated for an infection yourselves, you know that after a day or two, you're feeling a whole lot better, even though we may ask you to take the antibiotic for a longer period of time. So a decrease in discharge, redness, irritation, we would expect to go away. We want to monitor them for visual acuity because with a lot of these more superficial infections, then keratitis or iritis, aggravating open angle closure glaucoma are potentials. And then photophobia or severe headaches with nausea for the more severe reactions. Okay, so first line again, erythromycin, bacitracin, trimethoprim polymyxin, those are drops. The ointments would be, is going to be the drug of choice. Children, they usually would prefer that you use an ointment instead of drops. For contact lens wearers, so here's the really important. Anytime you're dealing with a contact lens, you must suspect or treat for Pseudomonas. Okay? Anytime you're dealing with an infection in the eye in a contact lens wearer. So here, the class of drugs that is best are called the fluoroquinolones. And I put 2 of them up there. There's others in this category, but ofloxacin and ciprofloxacin are fluoroquinolones. And you want them to quit wearing the contact lens. If it is disposable, then you throw it away. If it's one of the hard ones, what did you all do, Braden, with the hard lens? Did you make them replace it, or can you disinfect it?
We replaced them, but I think you can.
I read that you could disinfect, but I thought if it's Pseudomonas, I'd want to get rid of it.
Yeah, we almost always replace, but I think you can.
Okay. One thing is you go along and you're looking at drugs. I've only given you the generic names. If you will start looking at the word, usually the very end of the word will almost always tell you the class. So all of the fluoroquinolones are going to be oxacin, okay? So you'll see this over and over again. Erythromycin, zithromycin, those are macrolides. Okay, so if you'll start looking for that, you'll start to go, I don't know that drug, but I bet you this is the class it's in. So I can look at most drugs. If I don't know them, I can tell you what their drug class is. So just something to It'll make things easier as you're learning. Okay, so allergic conjunctivitis. So here we have no organism we're worried about. We've got an eye that is red and it is irritating, may itch, may tear a lot. So here we're trying to work on that blood vessel in order to get it, we're going to vasoconstrict it and to try to get the blood flow less, get the edema to go down, and we can give an antihistamine which will work on the tearing and the itchiness. Okay. The problem with these is that these are over the counter and people can use them and they'll overuse them. So how many of you know that you shouldn't use like nasal decongestants for more than 3 days? Okay, so the same thing goes with the eyes. If you do it long enough, remember where we talked about the body will internalize or down-regulate its receptors? It's the same thing, we're doing the same thing here. We're hitting them with an alpha adrenergic agent, and so over time it will just down-regulate and keep, or it will work through other mechanisms to keep that blood flow. So the eye is more worried about getting blood flow through the eye and oxygen delivered than it is whether you're uncomfortable enough or not. So it'll work through other mechanisms to try to overcome it. So people usually find that when they stop using this, then they get a rebound. They'll get more injection, more red eyes. That will go away usually in a few days. So here you'll see variants, but usually you want to use these for 2 weeks or less. And the other thing with the viral conjunctivitis is you can use a lubricant with it just for comfort. Until that, and then get rid of the offending. Figure out what is causing the allergy and get rid of it. Or lessen your exposure to it. Okay, so we talked about that. Okay, so usually the first line is going to be those vasoconstrictors, antihistamines, but we do have mast cell stabilizers and steroids. So let's kind of go through those. So you got a wide range here to use. So those antihistamine vasoconstrictors, that's going to be very self-limited, happens for a few days, and you're treating that. You would move on to those antihistamines with mast cell stabilizing properties and mast cell stabilizers when you've got a prolonged event. Maybe they have seasonal allergies. Maybe they have allergies all year round and their eyes are one of the major targets or symptoms. Then you would move to those agents. Oral antihistamines would be down the road, and then the ophthalmic steroids are way down the road, and those are for very refractory. Yes?
On this slide, it said viral conjunctivitis. I just want to confirm that was allergy, correct?
It's allergic, yeah, you're right. Yeah. Let me make sure. No, that's right, that's right, that's right. Let me back up. I'm mixing them in my head because you approach them similarly. So this is for the viral conjunctivitis because you're just treating a symptom. You're not treating the viral illness itself. You're going to let it run its course. So this is right. This is right. Now the next is allergic conjunctivitis, which we do similar. Sorry. Okay, so here we're going to get rid of the allergen, and then we've got this range of drugs to use. So again, you can use these as first line for short term. That Navcon A is probably the most common, and the two products in there are nefazoline and phenyramine. So the phenyramine is the antihistamine. Okay, that amine part at the end almost always tells you it is a antihistamine. That nefazoline, that part at the end is a indicator of a sympathomimetic. Okay, so let's talk about the antihistamines and the mast cell. So have you talked about mast cells? Did you? Yes? Okay. So mast cells are everywhere, and inside mast cells are a lot of the cytokines a lot of the mediators of an inflammatory response. So when you come in contact with a pollen and your immunoglobulins, your IgE start to rev up in terms of responding to that allergen, then they will interact with this mast cell and they will degranulate. So they'll dump all their contents. So one of their big contents is histamine. And your prostaglandins, your bradykinins, all of those things that either mediate an acute response or a prolonged allergic response are started in those mast cells. It also has the ability to recruit, so it'll bring in eosinophils and basophils and other cells that are inflammatory to come into that area to attack whatever allergen the body has perceived. So mast cell stabilizers, what they do, just what they say. They stabilize that mast cell membrane so that it will not degranulate as easily. Okay? The one problem with mast cell stabilizers is that you have to use them for a while before you can get effect, up to 6 weeks before you can get all, because it's a turnover situation, and any that have degranulated, it won't do anything for them. Okay. So often, if we've got people who have allergies that are very predictable, they come at a certain time of the year, we know that whenever the red cedar hits, they're always going to have allergies, and they know a defined time when those symptoms are going to be present, they can start these agents ahead of time, so like a month ahead. And that will help decrease their symptomatology when those pollens become full-blown. They also give time for antihistamines and steroids. If you're using them, they'll cover that time until those mast cell stabilizers can be in full effect. So two of the most common are there at the bottom. I can think of the olapatadine, sorry, and the ketodopin are probably the most common. And the top one is over the counter. I think the other one is a brand. It's a script. Yeah, Patnol. And
We have samples at their urgent care, but I think it's a script.
I'm pretty sure Platinol
We have
is.
samples.
Yeah. Okay. But the other one is over the counter. And it's a generic. Okay, so adverse effects, mostly it's going to be burning upon installation. One little trick you can tell people is to put their eye drops in the refrigerator. And as long as they don't mind dropping cold, it usually so if they don't, so either the sting or the cold it may bother them, but most people will prefer it to be colder. They can be used in pregnancies. Cromolyn is preferred in pregnancy just because very, very few side effects with it. And that's about it on these agents. And there's the box of the Cromolyn just to show you, and that kind of goes over the dose. The problem with mast cell stabilizers is they are a pain to take. They have very short half-lives, so you have to dose them usually 2 to 4 times a day. I have found that if you can get people to take them consistently twice a day, you get about as good as effect as you do with 4 times a day. But they're usually recommended 4 times a day. Okay, oral histamines, we usually like to stay with the second generation, though they're not as sedating, they don't enter the CNS. Benadryl would be one of the first early generation. Claritin would be a second generation. Loratadine, I put it up there because most people recognize the Claritin, but it comes as a generic and much less expensive as Loratadine. They treat, so cholinergic, here's the way I remember cholinergic is SLUD, salivation, lacrimation, urination, defecation. Okay, that's cholinergic responses. Anti-SLUD is anticholinergic, so anti-salivation, anti-lacrimation, anti-urination, anti-defecation. So you think about dry eyes, dry mouth, urinary retention, constipation. So that's the problem with using these agents, is they have a lot of cholinergic, anticholinergic effects that go along with their antihistamine effects. These are down the line. You do much better when you're dealing with eyes if you can do a local effect instead of having to rely on systemic, because you get then systemic side effects with them. Did I jump ahead? I see you all furiously copying or typing.
We said the histamines or the SLUD, or was that the antihistamines?
Cholinergic effects are SLUD.
Well,
Anticholinergic would be anti-SLUD.
What was the first and second you were saying? The Benadryl was first and third and was second?
It's a second generation. So the first generation antihistamines, like Benadryl, are the more, they enter into the CNS. So that's where you get more CNS effects. That's why we prefer these second generations. And so the first generation are very sedating. Like you can take Claritin in the morning and not be sleepy all day. If you take Benadryl, you're going to want to go back to bed. Yeah, most of you are shaking their head, so you've got some experience with that. Questions? Y'all have questions?
It's sludge, right?
SLUD.
SLUD.
SLUD, salivation, lacrimation, urination, defecation. Okay, so let's talk, I know you all won't, you're not gonna prescribe these, but you may run into people with them, so just to be aware. So these are refractory cases. And again, it's increase in intraocular pressure and cataracts that the system, or the topical steroids can threaten vision. Interesting though, they have come up and formulated what they call these soft steroids. I thought they were really interesting. So these soft steroids, when they are instilled, they are not allowed to enter into lower or deeper layers of the eye. So their ability to cause those effects are much less, and they can be used for longer periods of time. And I put them on in your handout just in case you run across them, that Allrex and that Vexol. Yes?
What's meant by refractory cases?
So if you're refractory, you don't respond. We do everything that we usually do, and for some reason you just don't respond. So that would be refractory. Brent, did you all use those at all? Have you come across those?
I'm not familiar, no.
Yeah, it was news to me when I read them. It must be fairly new. Why don't we take a break, and then we'll come back and we'll do the hemorrhage and the hyphema. So let's take about 10 minutes.